Good morning again. So I think fittingly for our first talk, it is entitled From the Ground Up, Assessing Institutional Readiness and Toolkit. And our two speakers will be in a panel session this morning. So the first is Dr. Susan Vadaparampil, and she is the Associate Center Director of Community Outreach and Engagement and Equity at Moffitt Cancer Center. She is a senior member in the Health Outcomes and Behavior Program at Moffitt and the co-program director for the NCI-funded ECHO training program. Her research uses a combination of behavioral science, epidemiology, health services, and clinical perspectives to improve dissemination and uptake of new cancer prevention and control innovations into both clinical practice and the community. She works on several areas relevant to adolescent and young adult patients and survivors, including genetic counseling and testing for inherited cancer susceptibility, HPV vaccination, and fertility preservation. And her work is influenced by transdisciplinary collaboration focused on health disparities and contributes to both the scientific literature and clinical practice. And then we also have Dr. Gwendolyn Quinn, who is the Olivia Wan Endowed Chair and Vice Chair of Research in the Department of OBGYN and Professor in the Departments of Population Health and the Center for Medical Ethics at New York University School of Medicine. Her research focuses on patient-provider communication, primarily reproductive health issues among adolescent and young adults, and sexual and gender minorities, and access to care for minority and underserved populations. She is a fellow of the New York Academy of Medicine and Science and the American Psychological Association. She serves on the board for the Alliance for Fertility Preservation and is chair of the Ethics Committee of the PanCare Life International Work Group on Standards for Reproductive Health for Adolescents and Young Adults with Cancer. So welcome to both of them, and we look forward to what you have to say.
Good morning, everybody. I don't think in a million years when Gwen and I came to the first Oncofertility meeting, basically in awe of Teresa and that something like this existed, that we would be speaking as the first session of this conference. So it's really a fan moment for us. So thank you, Teresa, very much for this honor and this opportunity. Gwen and I have been working together for a number of years on the issue of oncofertility in the AYA oncology population. And I think part of how we were invited to do this today, in addition to all the wonderful work that Gwen has done, is that for the past, is it 9 years, we've been leading an R25 NCI-funded training program that specifically focuses on communication for first nurses and then allied health professionals around this topic of now reproductive health issues, including fertility for AYA oncology patients. And I think that why we're doing this talk is not necessarily because we are the expert, but because we've trained now over 400 professionals from across just about every state in the US and internationally. And we've learned as much from them about how it is that in each institution, they're uniquely positioned to address the topic of fertility and fertility preservation as well as other reproductive health issues. So I think we're gonna tag team it, and I'll take the first part, and then I always like to be the opening act for Gwen to really talk about how it is that as an institution, we may need to do unique things, but there's sort of a broad-based approach or strategy that one could take to be able to implement and address the needs around fertility and fertility preservation for adolescent and young adults. So the objectives of our session today, many of you are probably familiar with the current professional guidelines that create the foundation for best practices in oncofertility. And early on, when Teresa was starting this work, we barely had a recommendation at that time from the American Society of Clinical Oncology. And now it's really heartening to see that many professional organizations have specific guidelines about how to uniformly address this issue and best practices in oncofertility. We'll talk a little bit about identifying components of an oncofertility program, and then Gwen will really delve deep into listing some of the tools for an Oncofertility toolkit. So in terms of current guidelines, the ones that many of you are probably most familiar with are those from the American Society of Clinical Oncology. And I think the words are important, but also the overall spirit of what these guidelines are encouraging us to do, and to do it for all patients. So the first is discuss. I think that's why we really jumped on this idea of communication. So much of this, of course, there's the clinical, medical, technical aspects of it, but it starts with a conversation. And starting that conversation in a time when patients are newly faced with a diagnosis is probably easier than it sounds. Yesterday, we got to do a mini session of our ECHO training program, and we really heard a lot about how different folks at different institutions come at this conversation. The other aspect of it is once you discuss, you have to have in place the systems to refer people to the appropriate support that they need. So whether that's referring folks who are interested in discussing fertility and fertility preservation, as well as thinking about the psychosocial support that one may need to be able to move forward along this path. Timing is another big part of these guidelines. And so the ideal timing is before a patient starts treatment. Those of you that care for AYA patients understand that this is a very hectic, chaotic, often emotional or overwhelming time. And so thinking about how do we maybe take out the having to think about it and systematize when we do this such that it's part of the initial workup or the initial consultation that these issues are addressed. Being able to be comfortable answering basic questions. That's where we heard a lot yesterday, both from the oncology care providers and the psychosocial providers, that this is not part of anyone's training. And so if you bring something up to a patient, you'd at least like to have a certain level of comfort to be able to say, okay, here's the next steps, or here are the options, et cetera. So I think those were kind of at the heart of the ASCO recommendations. We were especially excited that in the more recent versions, they extended the responsibility of having these conversations, not just to the oncologists or the physicians who are delivering the care, but also to all members of the oncology care team. And I think that's a signal from ASCO that we should each feel empowered to be able to have these conversations or to be that champion at our institution to really address these issues. The NCCN, which many comprehensive cancer centers like the one at Moffitt or here at Northwestern or NYU followed suit to have their first ever AYA-specific oncology care guidelines. They look very similar to the ASCO guidelines, but I thought it was also interesting that they put sort of raised the bar in terms of the timing with which this issue should be addressed. And so they recommend that for patients that are interested, they receive a consult or a referral for fertility preservation within 24 hours of a patient expressing interest. So again, as an individual or as a champion for this issue, that sounds wonderful, but as you all know, the reality of how to make that work in a smooth, streamlined fashion in your clinical setting, I'm sure many of you have these smooth, streamlined fashion examples that we'd love to hear later today, but there are challenges to that. So in summary, I highlighted ASCO and NCCN, but as you know, there are other professional organizations that also have best practices related to this, and they fall into the bucket of discussion, that is having the conversation, initiating the conversation about risk as well as options, referring patients to appropriate services. So we often think about the clinical. We talked a lot yesterday about partnerships with REI groups in settings where that might not be sort of readily available. But also, we talked a lot yesterday. I was so excited to see that we had many mental health professionals, including clinical psychologists, social workers, who really thought about how do we get patients kind of along the continuum of the shock of hearing a diagnosis to thinking about future and family building options, et cetera. And another thing that we talked about a fair amount yesterday, and we hear this a lot from our trainees, is that there's also a need to document. So we want a system, we want an efficient system, we want people to be sort of doing what they're best trained to do. And so a way to think about that is, how do we document that these discussions took place, that these referrals took place, for the benefit of both the patient, but also as a healthcare system. We'll talk about implementation and how we do this. Sometimes it's hard to measure, have we had an impact? Are we making a difference? And so it's critical as you're planning an oncofertility type of program to think about what are indicators and metrics of success that are measurable, that are documented on every patient. So in terms of the components of an oncofertility program, this looks like a very busy slide, and I think that you all will attest to the fact, those of you that have done this work, that it's a busy process in terms of thinking about multiple aspects of an institution to meet that one unique need of your patient. And I thought this was a really nice diagram in this article. It was a great article that talked about an overall sort of oncofertility program and what all would you need to consider, or what are things that you may be doing part of it, but what may you need to round out that program to really improve the quality, the efficiency of the program that you're delivering. So I'll talk a little bit about each of these, and then Gwen will give some more specific examples. But in general, we think about that communication piece. And ideally, that conversation begins before any treatment begins. And another topic that we talked about yesterday is that based on the current clinical practice guidelines, these conversations should be happening regardless of prognosis, potentially, age within that age range, et cetera. The conversations do need to be age appropriate, and so sometimes that means not only developing communication skills for the AYA patient, but also parents, family members, other individuals who may be part of that decision or actually making that decision on behalf of an individual. We talk a lot about evidence-based, and so I think we're in such an awesome position compared to where we were about a decade ago, which is that there has been so much outstanding research when it comes to what are best practices in terms of communication, how to initiate the conversation, et cetera. And so to the extent that we can leverage that in the way that we approach this in our institutions, I think it makes for a much better process. And there's also the consideration that we think about communication maybe as just the patient to the patient and provider, but even within a medical team, there's a dynamic. There's a way and a process by which we create buy-in potentially from those who may not feel as strongly that this is an important topic, et cetera. And so that's another part that should be equally considered when you're thinking about program. Decision aids are another area where there has been a significant amount of work to help people get to making a choice. At the end of the day, Gwen and I have talked a lot about this, and probably the reason that we have done Enrich and Echo is because we feel that it's important for patients to have the information, to know what their options are. Once that happens, and we feel like we did it in the best way possible, then it's really an individual choice about what next steps are for that patient, and not every patient should or has to undergo fertility preservation for our work or your work to be successful. I think it's really about that we've discussed, and that from a science perspective, we've created options that are available to patients. There are many decision aids that have been developed, and so I think that there's different approaches depending on the level of sort of electronic capability that you have, or the preference or the literacy level of the patient, or access to technology. that could be incorporated as part of how you support those decisions for oncofertility patients. And certainly materials should be age appropriate as well as literacy appropriate. That's something that I think we have a hard time with. Just the word oncofertility is very polysyllabic and can drive up your reading level of any materials that you develop, but also the technical terms, the jargon, and how do we get that to the point where patients can understand. And we've seen some wonderful examples, even from the folks that are here supporting patient advocacy, that are really patient-friendly, literacy level appropriate, and also inclusive. So we have to check our own biases at the door when we think about this issue of what does the future family option look like, and that can be very individualized depending on the patient, based on their culture, sexual orientation, gender identity, and that's definitely another area where I've learned a lot from Gwen about how to make sure that those considerations are also infused into the way that we think about providing decision support to oncofertility patients. With regard to provision of care, certainly thinking about age appropriate, that can be everything from access to certain types of professionals that may not be sort of there at the ready. We talked yesterday in our session about access, for example, to pediatric gynecologists. Those are, not easy specialties that exist in every type of setting, but really thinking about those different groups that need to be involved. And we really have to think about how this oncofertility experience is individualized based on the age of the patient, but also whether they're coming to you in the ideal time frame, which is before treatment begins, but what happens in many settings, which is after they've completed treatment and are now thinking about next steps in the context of survivorship care, the relationships that they bring to the consultation or the experience, as well as concerns, including patients' preferred support systems. So for some people, that means having a family member. Sometimes it's a partner. And a big one, which is, I think, how we started down this road, is helping clinicians to get comfortable with seeing this as part of their role or within their scope of practice, whether that's initiating the conversation and referring or providing more direct education and navigation, and thinking about the quality of the information that we might give to our patients to really support them in this process. A big one is referral pathways. So many times, at least at our center, how it happened was Gwen was at Moffitt, and that's how we started caring about oncofertility. So it's an individual, it's a champion. And so that one person may start the spark, but in order to really institutionalize something, you really have to think about how can we create the pathways to other clinical and support services. One of the things that we, in our first iteration of our training program, had as an assignment was for our oncology nurses to just find a local REI in their area, interview them, talk to them about how they may interface with cancer patients. And again, while that might seem like an easy thing, it was very challenging for some of our participants. And we're very grateful to some of you who stepped up and allowed us to refer our participants to you, to interview you, to get a sense of how to do this. We talked in our group yesterday, and many of our participants really, it's not just about finding a reproductive endocrinologist, but it's about finding a person who really understands the cancer context, who's in a way passionate or motivated about this patient population that's really going to be the game changer in terms of a referral pathway like that. We've also worked closely with our psychosocial support services, so our clinical psychologists, getting them up to speed about this particular population of patients and what their unique needs may be, et cetera. And for our REIs in particular, we are so grateful that they made a commitment to consulting with patients in a timely manner. So within 48 hours of receiving that consult. And it's interesting, Dr. Keefe, who is now at NYU, was one of the original folks that we started this with. And what I learned from him was that sometimes for patients, it may just be about having that conversation, to really feel like they had a conversation with a knowledgeable individual who was able to provide those options. And so the timeliness of being able to do that starts with that initial discussion and may be, of course, relevant to the procedure, but just having that initial discussion. We talked about documentation, so how can we systematically look to make sure that patients and providers or other team members are documenting the discussions regarding fertility preservation, but we would take it a step further to say, what was the patient decision? Let's make sure that that's clearly indicated, and then what procedures or subsequent follow-up did they have? I can't tell you how grateful we would be if everybody was able to do that, because it really does help in terms of even from a research perspective to say, where are the gaps? Where's the place where we need the intervention? Right now, we kind of guess at that because there may be very many providers who have these conversations, but we don't have a good way of being able to capture whether this systematically happens. With regard to training, we talked about that communication is important, but also the clinical content. And we try to balance these two things for the allied health professionals that we work with, because while having the appropriate communication skills is important, people need to have a general understanding of what the risks are of infertility in the context of cancer care and what the options are, as well as providing psychosocial support, really acknowledging and understanding where the patient is at, and navigation. So it's not just a one-size-fits-all, but there are different aspects. The venue, we have been very successful in terms of a web-based approach to doing this. So an interesting thing is that when Gwen and I first submitted the Enrich grant, which was the first R25, we actually had proposed it as an in-person training. And the study section pushed back and said, well, that's not really going to be feasible. That's not going to be scalable. So we begrudgingly made it a web-based training program. But in hindsight, that's what allowed us to have reach. And just to give you some context, in our first iteration of this training program, we trained a little over 250 oncology nurses. In this iteration, we are in our third cycle, and just for this class alone, we have 360 applicants. So I think there's a huge need for this type of training, but also that shows me that there's a huge interest in this topic and in this area nationally and internationally. So Teresa, when it comes to your visioning, please keep us in mind in terms of how can we work together to meet this demand for continuing education that's sort of distance delivered. We also really liked the format yesterday, where we got to work with a small group and deliver what we're calling Echo Light, where it was part of this conference, but had a lot of time for engagement and discussion, which was a really nice way of doing this. As far as the audience, I think I've mentioned that the ASCO guidelines are not just for oncologists, but anyone who is really working with that patient. And so thinking about advanced practice professionals, social workers, nurses, and psychologists is equally important. Thinking about your medical supportive care colleagues, if individuals are thinking about fertility preservation options and sort of basic things with regard to risk of infection, anesthesia, et cetera. And an important sort of step one that we talk about in our introductory module is that before you have the discussion with the patient, it's very important to have a conversation with the oncology care team to make sure that everybody's on the same page, that you're presenting a consistent message, et cetera. We talked a little bit about that the ideal time frame was sort of at that initial diagnosis, but in reality, many patients may be thinking about this during survivorship care and thinking about that it's not a one and done conversation, that there's many times where you might want to revisit the topic of fertility and fertility preservation. The guidelines were a great way to get this on our radar, but now that it's on our radar, we have to do better. We have to think about how can we continually address this need, because as you know, family building is in the context of a very dynamic life. And so people's wishes and preferences and situations change over time. And so revisiting this in survivorship care is a very important way to think about oncofertility, broadly speaking, across the cancer continuum, I would say. Psychosocial support we talked a lot about, but can't be understated in the person that's sitting before you, that's looking to you for guidance and information about not only their fertility decisions, but also some of the underlying stuff that you know, they may be sort of saying, no, I don't want to talk about it, or that's not for me. But until you peel back the layers a little bit to see what is driving some of what people are maybe immediately reacting to, then we really haven't understood where the patient is coming from. And so definitely anxiety, distress, thinking about body image, all of those are concerns to think about, as well as relationship context. This we talked a fair amount about yesterday, which is ethical practice. And so a lot of what I've just painted to you is very black and white. Do this, don't do this. You know, this is the framework or the structure. But when you actually have an individual patient before you, there may be challenges and concerns when you think about family context, culture, needs for sort of different approaches that are individualized and tailored. And so there are a number of ethical issues to consider in terms of disclosure of diagnosis, disclosure of infertility, just as a few examples. So thinking about and acknowledging that these exist and ensuring a way that ethics is considered as part of the training that we give. And we definitely, for our training program, see that that's very much a value add, is thinking about how we can integrate ethical issues in the context of sometimes fairly straightforward topics. So I don't know if all of you know this, but I think those of you that are trying to do oncofertility work are secret implementation scientists, in that implementation science is about taking evidence-based interventions and moving them into clinical practice. And each clinical practice has its own unique barriers and facilitators that have to be addressed. You cannot fit a square peg into a round hole. It's just not going to work. And so all of you that are thinking about these issues are actually thinking about implementation science types of issues. If we don't think about that, we're not going to achieve the high quality outcomes that we hope to, because the quality of how we're able to get something into clinical practice has a lot to do with the legwork that we do beforehand to make sure we've thought about the broad spectrum of issues to really get change into a clinical context. So with that, I'll turn it over to Gwen, and she can talk about toolkit.
Thank you. Good morning, everyone. It is great to be here, and I hope that you're not tired of Susan and I, for those of you who were there yesterday for 5 or 6 hours of us talking at you. But I think before I get into the toolkit, I was just listening to Susan's great presentation of kind of the structure of this, but it really made me think of something that we certainly need to think about for 2030, something that we've learned along the way, which is we all started off being focused on fertility and infertility and fertility preservation. But I think we've all learned in the years that we're doing this that the bigger umbrella is reproductive health, and that even patients who aren't interested in fertility preservation have reproductive health needs, and even those who are. And you've heard me and others talk about before that we often oversell this infertility message and don't talk enough about contraception, or don't realize that particularly in the youngest adolescent patient, male or female, transgender, gay, lesbian, that they're challenged to think about the future in terms of children because they're still stuck on other aspects like, I don't like my body, I have these scars, no one's ever gonna love me, I'm never gonna find a partner to have a child with, so I'm not interested in that. Or even the more complex, like we talked about yesterday, the silent sufferers, the patients who say no, no, no to any conversations about fertility because they won't tell you that what they're really worried about is that their cancer somehow has a genetic component and they're gonna pass it along and they don't want that to happen. So sometimes those of us in the communication field have to be proactive and say, are you thinking about this? Are you worried about that? But at the same time, balancing that with sometimes no means no. And I don't want to hear about this, or thank you for telling me, about this or giving me this information, but I've made up my mind. And then another key point is that, yes, survivorship presents a second opportunity to talk about reproductive health and what it means. And maybe it's not the same care team at that time. So that's why documentation can be really important. But even if it's documented, you're working on a survivorship care team and it's documented in the literature that this patient had a discussion about fertility preservation, said they weren't interested, did nothing. You don't really know what the patient retained from that time period when things were chaotic. So it could be an opportunity to revisit it, to say, you might have heard this already, or maybe you don't remember. Do you have questions about this? Do you want to revisit it? And all of those things, I think our institution should have resources to be able to address. And even the distress and anxiety that may come with a patient saying, you're right, at the time of diagnosis, I said I didn't care about it. I wish I hadn't done that. I wish I'd done something differently now. What are the options for me? And one important part of our toolkit that I don't think that we have a slide for is, as Susan said, like sometimes people just want this information. And at one point we did a study, and I don't think we ever published those data, we actually looked at our data at our institution, and 92% of all patients who were referred to a reproductive endocrinologist only wanted the telephone consult, and it didn't do anything else. And that's also important, I think, for oncologists to be aware of too. It's not like every one of their patients is going to be moving out of their system, moving out of their care to do that. They all want this information. And for a lot of times, and this is another David Keefism, this isn't just an opportunity to grieve. There may not be time to do anything. There may not be resources to do anything. You may not have the wherewithal to make a decision. But in a sense, just like not voting, that you're not doing something was your decision, and you can grieve that. Like many people who suffer from infertility outside of a cancer diagnosis just often have to grieve that reality. So with all that aside, there are various checklists about getting ready to do to do reproductive health pathways within your institution. The other thing that I've learned is that building a fertility preservation or reproductive health program for cancer, it's not like if you build it, they will come, and you can build it and walk away from it and go on to something else. This is a orchid that needs a lot of tending and pruning and the right temperature and the right amount of water and a lot of monitoring, because what worked for 12 months, all of a sudden in month 13 isn't working anymore. Or the people who are all invested are no longer there, and there's a new team, and the new team won't agree to the same terms. When we were building that program at Moffitt, we had many reproductive endocrinology groups who approached us and said, we want your patients, send your patients to us. We said, okay, well, will you agree to a phone call in 24 hours and an in-person visit if they need it, even in the hospital in 48 hours, regardless of weekends? No, we're not going to do that. Oh, and by the way, only send us your women and only send us people who have insurance. And so it was challenging to find a group that was not in it for the money and really was just there. And mostly it's only academic reproductive groups that are able to do that. And that is a sweeping generalization. I'm sure that that's not the case in everywhere. But, you have to also be willing to give in, like, to your demands. Like, we demanded this 24-hour phone call and this 48-hour in-person visit if it was required or wanted by the patient. But the reality is it doesn't happen like that all the time. At the time, I think there was a 2-person group, and they just couldn't always do it. So we're always checking in with the nurses. They say, I'm calling and calling, and my patients are not getting return call. So then we had to establish a dedicated phone line that was just for the oncofertility type of patients. So all of these tweakings and things, it's job security if that is your job to do that, because it will always need attention. And checking in with the patients who are receiving this care. What was the experience like? Did you feel that the person understood you? And as physicians or as oncologists are coming on board and leaving the institution and new ones coming in, there's the relationship building with them that needs to happen over and over again, because most oncologists want to know to whom their patients are being referred. They want to know that if they want information about what's happening in the REI clinic, that they're going to get it, or that they have access, or that the REI will call them and discuss things with them that are based on the specific needs of that patient. And so sometimes as we have to be the champion that arranges those 6 a.m. breakfasts for them to get together and talk to each other, sets up the phone call and moderates the phone call. So all of these things have to happen in order for you to do the first step of having these referral pathways to these reproductive health. I focused on reproductive health specialists, but also mental health professionals if you don't have them in your institution. So we have found in our training that obviously mental health professionals have a lot of training in communication, but they lack the medical content knowledge. And as the reverse for the oncology team. They obviously have all of the medical content, but less communication skills training. Another aspect of this that Susan touched on briefly is this documentation system. Many of us now, or maybe all of us, have electronic medical records. We have Epic or some system like that that can build a flag, but is checking off a box like we do for smoking cessation or documentation of fertility preservation. Is that really documentation? If a patient should decide to challenge this in the legal system, is the fact that a box was checked enough to protect the institution from any legal liability? I don't know, because fortunately, I don't think any of those cases have ever actually made it to a court system. But we know some that have been resolved through mediation, and it's always been documentation of the chart of a note, an actual written note about that has not allowed the case to go any further. If any of you know of any cases, I think we'd like to hear about them and talk about what happened in them. And then training for the providers. So even if you build this program, not only are oncologists cycling in and out of your institution, but the nurses and the care team are cycling in and out. And for many years when I was at Moffitt, we had built this program, and all of a sudden I got the call one day from a nurse in hematology. She's like, "We don't do anything at this institution for fertility preservation." I was like, "What? I mean, don't you have the brochures in there? Haven't you been to the training?" She's like, "I just started last week." So, there is, as people are getting onboarded, it's not part of their onboarding training to know about this type of resource that's available in the institution. I another time had a nurse call me and said, "I see your name on the back of this brochure, and I just want you to know I've taken all these brochures out of the patient waiting area. You can come pick them up if you want them." And this was in the breast program. And I said, "Why can't the brochures stay there?" She said, "Because none of us know what this means. And patients are coming up to us asking us questions about this, and we don't have training, so we don't want this here." Another story, and I'm finding in my old age, I have so many stories to tell, I can't get past the first slide, but we were fortunate that Teresa gave us funding one year to try out a prompt. So we created these squeezy eggs that had the acronym on there, TALK. It was specifically aimed at parents of teen girls with cancer. Talk to your provider about fertility. Ask your daughter about her wishes. Listen and know your information. And so we developed all these eggs, and we gave them out to 6 institutions to have in their new patient kit. And then we did a follow-up with them about how they were being used. Not one institution used them. They threw them away or they put them in the back storage room because the nurses didn't feel that they had enough training. They did not want parents to ask them questions about it, or they did have training, but they didn't have any place to refer these patients to. And this was, I think, prior to when egg freezing was still experimental. There just weren't any options for these girls, so why talk about it? They didn't have the kind of mental health training that we would have needed to have them say that there may be just an opportunity to grieve. It's an important thing to understand that fertility can be lost even if there's nothing that can be done. It's like a side effect, a late effect that you have to discuss. So it was a lesson, again, that can't emphasize the importance of training in every kind of setting. And it also goes back to the Susan slide about the changes of the ASCO guidelines. So I'll take a little bit of credit for the fact that I argued that for the first two sets of guidelines, it said refer interested patients. And I said, this can't be a patient issue. It can't just be about patients who are interested. It's also ambivalent patients. If a patient says, I don't know what I want, is that interest? No. But that ambivalent patient also needs that referral to get information. They're just not maybe ready to make a decision yet. So, and they don't need to make decisions at the first time that this is being talked about, for the most part. The other important development for the institution is having support in this fertility preservation process for those who are choosing to move through it. For males, that may be a little more straightforward, but for females, some hand-holding is needed, and particularly if they're leaving your institution to go to see another provider, they're also worried about, do both of these people who are providing information for me have the right information that they need from each other, and are they talking to each other? And maybe that comes in the form of psychosocial support services, but also can be patient education and tools. So how to build, we should say build and maintain an oncofertility program. Susan mentioned a lot about the need for a champion, but even the best and most enthusiastic of a cheerleader is probably not going to make a lot of progress if you don't have support from the very top, from the cancer center director. And even if that's ambivalent support, which I would say that we had at the beginning, but then once this became an NCCN guideline, once other entities said how important this was, all of a sudden the leadership was like, oh yeah, we have that, And as practice and guidelines change, and they may change specifically for the cancer type, we know that the breast cancer in particular and GYN cancer is continuously changing and updating what our best practices for that. And so our oncofertility program needs to be mindful and reflective of those changes. Defining the roles of the team is another key point in doing that. Certainly getting a group together who are interested, but you heard us talk about yesterday, if you were in our ECHO training, that I think what led to the success of our getting this grant was that we were fortunate we had funding from the American Cancer Society to do a national survey of oncologists and their awareness of the ASCO guidelines when they first came out and what they were doing with regard to fertility. And there was very low recognition of these guidelines, very low knowledge about risk, and people were not doing anything for the most part. And their number one reason was, I don't have this training. I was trained in oncology. But they were happy to give this to another member of their team. And so at the time, we made the decision that our target audience was nurses, that they had the time. And many times, we'd also done qualitative interviews directly with physicians who'd said, I have 45 minutes for a new cancer diagnosis, and that's barely enough time to talk about the disease, the treatment plan. To throw fertility in there on top of it, it's just not going to happen. But they were happy to turn that over to another member of the team. So I think, and I'm looking around the room now and I see Natasha and a lot of oncologists who are themselves the champions. They're probably also happy to have the rest of the team be trained to have an extended conversation. But I think more and more you see the younger physicians who do see this as part of their training in oncology. Whether you have formal education for your team or whether you have an in-service. So also looking around the room, I see some former Enrich and ECHO participants. I see some of our I see Jen Levine and James Klosky, some of our co-investigators on there whose work permeates out, and we also move institutions, and so that creates opportunity for those of you to train others within your institution. And also, I know from working in several cancer centers that people like to do their own thing, they like to brand their own thing, but there's a lot of patient education materials out there at the Oncofertility website, other institutions, Livestrong, maybe some of the organizations who are out here. So you don't necessarily need to start, to reinvent the wheel, but take what exists and brand it and make it fit for your institution. Make sure that the services that are being offered are truly things that you can offer, and that the telephone numbers are right and accurate and the website is up to date. And again, that's something that, whether it's an actual printed brochure or it's a PDF that's online and accessible, those things need to be updated on a regular basis. So how do you gain support of the administration? So one thing is identifying key stakeholders, which also include patients. Happy patients who got this information and now have beautiful little kids to show you, and unhappy patients who didn't get this information and feel remorseful and regretful or even angry for not getting this information. Hopefully they're not from your institution, but from somewhere else. And take these places, take these people and these stakeholders to the administration to build this case. So the patient stories are usually really powerful to moving people. We talked about this yesterday. It's something that the Quality Oncology Practice Initiative takes into account to some effect, which is kind of showing you where you stack up compared to either people at your own institution or people at institutions similar to yours. So that's an interesting maybe research project that people can do, is what are the comparisons of documentations of fertility preservation across the various clinics or the organ sites in which cancer is most likely to affect them, and show those data. You only have 50% of your providers who are documenting patient fertility preservation. We did that with, again, some funding that we were fortunate to have from Livestrong, and wrote a paper called "If You Didn't Document It, It Didn't Happen." And we were able to show the various groups within our institution what their level of documentation was. And one of them was a big champion who was all for this, and I know that he was actually having those conversations with people, but he wasn't documenting it. So it was a learning lesson for him, kind of holding a mirror up to people about their practices, that he needed to get better about that. Highlight the resources that are already there in the institution and kind of minimize the need to have to build new institutions, that is, have to spend money if you don't have to. And of course, it would be ideal if navigators were built in, and I see more and more people. No one will ever replace Kristen Smith and what she does, or Joanne Kelvin, who's now retired from Memorial Sloan Kettering, but using these institutions, contacting them, finding out how they funded their programs, what the roles are of their person, how they continue on those roles. Again, nobody can be exactly like anybody else. Every institution is different, but that does help leadership understand, okay, this has worked in other places, it's sustainable, patients are happy. Maybe you bring in the aspect of risk management and how it can reduce your exposure for litigation. Hopefully you know your leadership and you know what buzzwords work best for them. And then also, as I mentioned, evaluating your program. Formally is ideal, and I think lots of us could publish lots of data if we had time to talk about what's working and not working within our various programs and comparing them. But if you can't do it on a formal basis, on an informal basis, checking in with patients, checking in with nurses, checking in with doctors, reproductive specialists, mental health professionals, what's working, what's not working. So again, the ASCO guidelines and emphasize, these aspects of discussion and referral and encouraging patients and documentation. There also are, I suspect, maybe Teresa or someone will talk more about this today, that there will come a time in the not too distant future where maybe ovarian tissue cryopreservation is no longer experimental. And so as these guidelines change, then we need to go back to our institutional practices. And some places are not even doing ovarian tissue cryopreservation experimentally. So how are they going to jump into that? And that's another thing we can do for our teams at our institutions, is kind of tell them what we think is coming down the pike, and things that they should prepare for. Susan covered this. So we have this also busy kind of infographic that is kind of like a quick referral guide for the topics and the time points. And here we do use the expanded definition of reproductive health. So risk of infertility is obviously best communicated at the time of diagnosis, as well as fertility preservation. But it's also an important time to talk about sexual functioning, particularly for people who are in relationships, to say what they can expect and what tools that you have to overcome that. That's something that we talk more about, in ECHO, about having those conversations and not having them be heteronormative, not assuming that the person in front of you is heterosexual, and being prepared to either give patient education materials or refer to mental health providers who have experience with those populations and can talk about that. I'm surprised that in this day and age, my current institution, they developed this great little brochure to help women who were laboring walk, and where it was a safe way to walk, and let them know that they had walked a mile as they were laboring. But right on the front cover was a picture of a white man and a white woman. And I'm like, this is 2019, and very few of our patients are white, and many of them are not partnered in male-female way. And how inclusive do you think this brochure is? If you see a white man and woman on the cover, do you think that that's for you if you're in a same-sex relationship, or you're African-American, or you're Asian? And they said, yeah, you're right, but these were free stock photos. So, which is, that's better not to not even be shown than to potentially, if you offend one person, it's one person too many. And also, as I mentioned, talking about contraceptive and contraception, not only for the prevention of pregnancy, that we don't want that to happen for anybody who's on treatment, but also the right type of contraception based on the cancer that the person has and the treatment that they're receiving. So for example, people who have IUDs, if they're going to be getting pelvic radiation, those often need to be removed. And that's sometimes something that the oncologist doesn't know, but that's another benefit of having a relationship with a reproductive endocrinologist or GYN oncology, to be able to make those very personalized recommendations. And then addressing contraception, romantic partnerships, sexual functioning, and body image on active treatment is also really important. Checking in, how are you feeling? I liked when we were watching one of our videos yesterday that the social worker, instead of saying normal, I think we tend to say normal too often, to say this is common. It is common to feel this way. A lot of people feel this way. We have support groups if you want to talk to other people. We have mental health professionals if you want to talk alone. But you are not alone in your feelings. And then, of course, in survivorship, revisiting all of these things again, but with a different kind of lens. So if there wasn't the opportunity to do fertility preservation, and if there's subfertility or impaired fertility in survivorship, what are alternative family building options, which you may also have discussed when you were giving all the information at the time of diagnosis, but maybe a lot of that didn't sink in. There was too much to think about at the time. And still I'm surprised, for as long as I've been coming to this conference and we've been talking about this topic, how many patients have never known anyone who has used a surrogate, or gotten a donor egg, or used a sperm donor. And I think it's because patients tend to go underground about this. So we all know that it's, I'm not going to say normal, it's common, or not as common as natural conception, but neither is cancer in this population. And so to the extent that patients feel comfortable talking about this part of their journey when they're far out from this, I think it would really be a help to patients coming behind them, that this is how it worked, and this is how we did it, and these were the considerations that we had. And of course, things are changing. I now live in a state where paid surrogacy is illegal. But that doesn't mean people in New York don't use surrogates, but they use them outside the state of New York. And as we'll hear from Joyce Reineke tomorrow talking about the changing legislation landscape, some of these things may be changing, and the way we counsel patients may be changing if our states have adopted some of these insurance ability to cover through insurance now. So there's lots of ways to educate. As I mentioned, it doesn't have to be attending formal training. Although we've had a record number of applicants this year, we always, if we can't take everybody this year, we will wait list you for next year. And we're going to put our heads together and try and figure out ways to expand this training. And maybe everyone doesn't need the 8-week online. They need, something else or a shorter version. And we're not the only game in town. ASCO has Focus Under 40. There are other kind of like mini trainings that are more geared toward physicians, but still a little something is better than a whole lot of nothing. But I encourage you all, as you are back at your institutions, to do things in a less formal way. Having a grand rounds and raising the topic, or a lunch and learn where you gather people together and say, who's interested in this, or what do you need to learn to make you feel more comfortable to have this be part of your practice. And so there are a lot of people who ideally could be part of this team, and we've mentioned all of them today, but I think one that gets left out often is urology, and the lab personnel who are involved in this, and the expediency with which sometimes this has to happen. I used to give this talk about fertility preservation to all the incoming fellows, and always I would be standing in the back of the room with their arms crossed, and I learned to figure out who they were. These were the surgical fellows. Well, like, this doesn't apply to me. I am not causing the infertility. I don't need to know this. But so I learned to change, and I learned from Joanne Calvin, when I learned to change my talk to say, it's not about who's causing this, but it's about the cancer that's causing this and how the cancer works. And you as a surgeon are in an ideal place, particularly women with breast cancer, to talk to them about this so that this window of opportunity that they have as they're recovering from surgery before they start chemo radiation. And when they saw their place at the table, and when I learned to restructure how I gave the talk, then they were interested. So it's learning that occurs on a two-way street about how best to present this. So I learned that talking to an oncology team about, you are causing this infertility, you are administering this chemo, does not go over well with anybody. And they're like, you can leave. But focusing on the cancer and what the cancer does, and we're all together in this battle against the cancer, was a more palatable approach. I mentioned this about collecting, materials from other places and using them at least as a starting point to develop materials for your institution. And also, like Susan mentioned, it's really important if you know the audience of your community. So we're not all white English-speaking people. And different religions and different cultures have different perspectives about things relating to fertility and fertility preservation. And so if that's a big portion of your population, whether it be that you need those materials in Spanish or you need them culturally adapted for your Orthodox Jewish population, know your audience and know that, again, just like I mentioned with the white heterosexual couple, that people are not going to pay attention to something if it doesn't look like it is for them. I think I'm going to try and skip ahead for a little bit for some of these slides. I think that they're available if you want them on the app that Teresa mentioned, because I want to give time for us to have a discussion if people are interested about this. But this is maybe kind of what a pathway could look like if you have it within your specific clinics, as you may have for many other things like recommendation for genetic counseling or for a clinical trial, and helping create these pathways, which may be very clinic specific, could also be a way that you could help your institution. The last thing I'll mention is about Fertility Scout, and Joyce Reineke may talk more about this tomorrow. But if you are in a place where you do not have access to reproductive specialists, this is a tool that can help you. Or if your patient needs something that your reproductive specialist team or your institution doesn't offer, like testicular tissue cryopreservation. So you can go to this page, fertilityscout.org, and it's pretty much a GPS locator. You can put in either your location where you are, or perhaps your patient has come to you for a second opinion and they're going to go back to some other state for care. You put in their zip code where they live. It's a drop-down menu for the fertility preservation service that you're looking for, and it will show you what's available in those areas. And typically, these are vetted, that these are, I don't know if it's still called Sharing Hope at Livestrong, but institutions that participate in reduced fees and costs for cancer patients. We talked about some of those already. So in summary, we all need to create programs that meet the needs of our institutions today, 6 months from now, 2 years from now, a system that we need to check into. Developing people who are passionate about this, who are interested in this, and don't kind of have the mentality of this isn't in my job description, or I only work 40 hours a week. And just because there are barriers does not mean that they're not insurmountable, and that you have a whole team of people here in this room, through the app, through a variety of places that you can say, did you experience this? What did you do? Give me some tips. One thing that we learned years ago when, before Fertile Hope was acquired by Livestrong, and when Fertile Hope had a Fertile Hope Center of Excellence, and that may be something we want to revisit for 2030, is bringing back this designation, is that the very first thing you need is a policy. Now, policy is not law. It doesn't mean that people have to do that. But if there isn't a policy in your institution for doing this, it can be hard to build the rest around it. And if you can sneak in that policy and then go to leadership and say, hey, we have a policy that has no legs to it. There's no resources. There's no pathways for this. That can also be a way to get the ball rolling. So I'm going to end there and invite Susan, and I will sit here for a couple minutes and take your questions or have discussions. We'd love to hear about if there's been any legal incidences that you're willing to share in a de-identified way from your institution, or some of the barriers that you're experiencing, and maybe as a group we can talk about overcoming them.